Yeah, I think this is very important that AML is in fact extremely heterogeneous. I think the other malignancy that I think has very similar paradigm is lung cancer, and over time we're seeing that there's not one lung cancer. There's 5 or 6 different types: ALK mutated, EGFR mutated, PD-1 high, non-small cell, so on and so forth. And each of those has very unique presentations, unique response to specific therapy. And if you can identify the right molecular group, do the right therapy, you can really improve outcomes and reduce toxicity by giving non-specific chemo. So I think in AML is the same paradigm. I think the 4 big groups that we look at in the frontline setting are FLT3 mutations, very potent, very active FLT3 inhibitors, both single agent and in trials, and hopefully soon in the future as standard of care in combinations with azacitidine chemotherapy. IDH1, IDH2, same story, very effective as relapse single agent, but even more so emerging data suggesting could be really effective in combination with azacitidine in the frontline setting, and maybe even combined to aza-venetoclax as a triplet. Some of the early data from our center, again, showing high MRD negativity and durability better than aza-ven or aza-IDH alone when you do the triplet. And the third group is now becoming TP53. So we're looking for all patients in the frontline AML setting for the TP53, both mutation as well as associated chromosomes and variant allele frequency. And those patients, we're really putting them heavily into 2 clinical trials: azacitidine with CD47 antibody magrolimab and azacitidine with APR-253, which is a TP53 folding inhibitor. We think that these 2 drugs appear to be, again, early data, but appear to be major improvements and specific agents for the AML TP53 population. So I would look for those, and if you find those, then consider referring them to a center that has these studies. They're open across many places in the US and Europe also now. So you may be able to get your patient to one of those. And then the fourth, which is very new, but I think of interest, is the MLL rearrangement. This is the translocation 11 with other partners. And there is a drug, menin inhibitor, that was presented at ACR, Syndax menin inhibitor, showing early but very striking complete remissions as well as cytogenetic remissions. So if you have a relapsed patient, in addition to FLT3, IDH, TP53, think about looking for MLL rearrangement. You can do that on cytogenetic or FISH probes. And if you find that, I think it would be great to send that patient for menin inhibitor. These could emerge as a major targeted breakthrough for that population. So I think in the treatment landscape, these are probably the 4 therapeutic, molecular cytogenetic groups. Of course, in cytogenetics, you also want to be looking at the newly diagnosed patients for core binding factor, inversion 16821. If they have that, those are people who ideally benefit from addition of gemtuzumab to the standard anthracycline cytarabine induction. And you also, for sure, number 1, want to be looking for APL, translocation 1517. So I guess really in aggregate, we're talking about 6 different subsets when you combine cytogenetics, APL, core binding factor, MLL rearrangement, and then 3 molecular groups: FLT3, IDH1, IDH2, and TP53. So you will see that ELN and NCCN is also reflecting, these kind of similar tests. These are covered by insurance for the most part, almost I would say 90 to 100% of the time. And so you don't want to miss these opportunities. And I think in the future, 3 to 4 years from now, we're really going to get away from this age and fit for induction and not fit for induction debate and move to what lung cancer has done now, which is just what molecular or chromosome aberration do you have? And if you have that, you would benefit most from this targeted or directed therapy plus backbone of whatever standard it may emerge. And that's going to be quite exciting, I think.